no, that I am. I will introduce some subjects in the MRI machine, and to practice centered praying inside the MRI machine to see what happened because MRI can tell us about the functional imaging of the brain. Then it's going to be very, very amazing. Really, it will be amazing.
I would be very interested. Yes, very interested.
Because I also study several publications on hypnosis and also praying and in other ways of doing. And there are similar issues, no? But centered praying, we have proof, and Bob have proof that is useful. I will tell you something in advance. The control women, I mean, they were not, they were normal functioning. But you know what they told me? After practicing centered praying, I feel quietness. I'm very quiet in my life. I mean, they were normal, but after practicing, because we did the same in the patients and the normal subject, the women all told me, "Oh, I feel very quiet. I don't feel anxiousness. I'm not anxious. What is this? Huh? This is." It is also for normal person, for regular person.
So it's useful regardless, right? And that's a good point to make in the paper, that anybody that has a certain criticism about whether it changes neuroanatomy, and they might be critical, and you could say, after you've had that experience, you subjectively feel much more calm and more relaxed, and that it's a positive happening, and you go from there. Yes.
Have you practiced hypnosis with your
I was
patient?
trained by a hypnotist, actually, and I have done some exercises with him, and I've tried to do that with patients before, but I really like the idea of moving it more toward mindfulness.
Mindfulness.
And yeah, I think that's a little easier for me to introduce people into that same kind of thinking, where you focus more internally and you gradually eliminate the distractions of the external world in order to move towards something that's suggested to you, if that's part of a hypnotic pathway, or something that's suggested to you in terms of normalizing physiology. And I like the mindfulness kind of meditation.
Let me tell you, I forgot to tell you that I have done many studies on consciousness, even theoretically, and also applied to coma, brain death, and so on. I was involved. I was the main expert in the case of Jahai McMash. I don't know if you have from California. I will send you the data, because this girl was diagnosed with brain death in California.
Pick up my bag on the floor. Just tell them. Okay, go ahead.
In California, this girl was diagnosed with brain death in California, and a huge legal debate began between the mother and the hospital. And the American Academy of Neurology called me, and then I described a new state of disorder of consciousness. I will send you the paper. It's already published.
Yes, I would love to read it.
Yes, and also, Bob, I can give you my ResearchGate website, because then and all my papers, I have more or less about 6,650 papers.
Okay.
And then I would love that you read it and tell me your ideas and so on.
Okay. Well, I don't know if others are going to join us. We can give them a few more minutes, but Klesel tells me he has a PowerPoint presentation. You want to give us an overview status of the project right now, Calixto?
Yeah, I think we should get started because you never know on time, right?
Yeah, how much time do you have, Harvey?
I blotted out an hour for our time. Then I've got something else I've got to take care of.
Okay.
Okay,
Calixto,
let's
why don't you
begin.
go ahead and start, Calixto.
Well, let's begin. And I told Bob that to discuss the the course of the project, it would be better if I present a PowerPoint, no? Because then I have the data in front of my eyes. Well, I will tell you that the Harvey knows very well the concept of PTSD. I mean, it's a stress disorder, the mental condition trigger. This is very important, or witnessing trauma events that they are very common in the modern time, in modern times. Oh no, I mean since the beginning of of humanity, and it's characterized with several symptoms as flashback, anxiety, depression, stress, fear, suicide, flight. And the causes, we all know this is very important for USA. I have been studying the studies in veterans coming from the wars, Vietnam, Afghanistan, and it's amazing how they suffer. The patients, the veterans have many. The veteran hospital are studying many soldiers complaining PTSD. Also very important is a physical sexual assault, including childhood abuse, domestic violence, and so on. Natural disaster. For example, you recently a hurricane hit USA recently, and it was a disaster. And Cuba received many hurricanes all years. What about earthquakes, accidents, life-threatening medical diagnosis? For example, you have a cancer. The symptoms are, you can describe in group: intrusive memories, flashback, nightmares, and distressing thoughts, avoidance. I mean, you don't want to see a place, you don't want to see a person that trigger your memories of that terrible event. Negative change in thinking and mood, feelings of hopeless, emotional numbness, and it's difficult for them to maintain relationship. And this is very important. Hyperarousal symptoms, hypervigilance, irritability, problem with sleeping, and exaggeration start the response. It's amazing. For example, I was a study that exaggerated start the response appear in PVS, persistent vegetative state patients. This is something that I have to compare because they are very difficult situation, PVS with PTSD, but it was something that caught my attention, and I will study.
I couldn't understand.
Hyperarousal.
You said
I beg your pardon?
PBS. I couldn't understand what you said.
PVS, persistent vegetative state.
Oh,
It's a
vegetative. Yeah.
vegetative state.
Okay.
But hyperarousal is a very interesting symptom, because the patients is that they are reacting too much to the surrounding to the surrounds. Difficult in sleeping, irritability, loss of concentration. They are that's what I say. They're easily started. Hypervigilance, and you are there over aware about what is happening when in his surrounds. It's a very interesting symptom. I want to tell what happened in USA. The USA is very important, and there are a lot of resources that are in the health system in USA for treating PTSD, because of the war, the soldiers, because of the sexual abuse. And for example, in firefighters, in different wars, in assaults, because the violence is something very common in nowadays. It's very important. That's why I asked you, Bob, that I was interested in studying PTSD related to sexual abuse or rape, because this is a problem that is being discussed in the whole world. You know that there are many campaigns to stop violence against women, and there are countries that they're really the women do not mean nothing. They are abused. They cannot decide by themselves, and it's something that the humanity should work against this violence for women. And the traumatic effects of sexual assault are emotional, cognitive, behavioral, and physical, because the woman really is not happy anymore, and they are, you as a psychiatrist, Harvey, you have, I'm sure you have treated many women who have been abused by parents, by their own parents, by, or have been raped, and there is something that is kept inside these women for a whole life. They don't live without this terrible memory.
Yes.
Whenever you want, you can stop me and to talk about anything. This is not a lecture. This is a
I'll
discussion.
give you an example.
You know, the symptoms are.
There was a woman who was raped, who was an opera singer. And after the rape, she opened her mouth to sing and no sound came out. She couldn't produce music anymore. And she had a trained, beautiful voice that we worked with her in special group therapy, and even used a robot that contained something that she used to sing so the group could hear her voice and let her hear herself and reintegrate. And it took some weeks, but in the end, she was able to sing again. But until we had a major intervention and understood many of the contributing etiologic factors, she had made, with previous attempts, absolutely no progress.
Let me tell. I remember a teenage girl that went to my outpatient, and then she had problems with their relationship with her boyfriend, because whenever she wanted to do sex, she was unable. And then with a lot of asking, she didn't want to tell me anything. The problem that her father, raped her when she was 9 years old, 10 years old, and continue. But the problem is that her first, sexual experience that were really good, she remembered with her father. And then whenever she had a relation with a new man, she remembered her father, that she was doing sex with her father, and she couldn't, even she was married, and she couldn't have sexual relations with her husband, because she remembered, oh, it was amazing. I needed to treat her and to work with with her husband, and finally she was okay. But it was very difficult for me.
Understood.
Bob, any idea, Bob? Well, and then we began this century prayer, because really this is a protocol that continues several ideas we are doing with century praying, led by the most handsome man of America, Bob Hesse. Do you agree? Do you agree?
El guapo.
Guapo, 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 guapo.
El guapo, guapo.
I love this photo. Bob, this photo is which Congress is this?
Which,
because he
oh, this was the interview by the president of University of St. Thomas. It was a podcast by interview from him.
it's amazing. He's guapo, como se dice en Cuba, un macho guapo,
Macho guapo.
macho guapo. And then uh, we already have training in century prayer. My daughter and my son-in-law have a study mainly with this. Well, Bob personally taught them, but here in this YouTube site that Bob presented a group of videos that really you can easily learn to practice century prayer, and that's how we have done. You know, to have this site. Every time we begin a new protocol, we go there, study it together, and so on. And then the protocol was because I asked Bob to do this protocol in women who had a sexual assault or rape or whatever. Really, this is a mistake. It was not 55 years; it was 35 years. Who suffered sexual assault or were abusing children. As the protocol said, they all wanted to be praying using God's name. I mean, this is very important. And no psychotherapy medication, no other treatment. And it's important we study these patients neurologically and with CT scan to say that no lesions in the brain. I mean, no stroke, no tumor, no anything, because it was important for us that the patient only were complaining PTSD. All soldiers will receive training with contemplative praying. Of course, the other 5 women were per in age with patients and as a control group. We applied this scale coming from the DSM-5. I think that is very, very useful because it's simple, very simple. For example, repeating disturbing and unwanted memories of the stress, especially not at all is 0, a little bit 1, moderately 2, quite a bit extremely. I mean, very simple scale. It's simple to apply to patients that you can handle, and that's why I mean there are many scale for to evaluate PTSD, but at the end, coming from the DSM-5, I think that this was very, very, and it's quoted in many articles. That's why we use this with this scale. You see, it's very simple to apply. Have you used it, Harvey? Have you used
it
this
before? I have used it before. Yes.
Well, tell me your experience.
It only takes about 10, 15 minutes for somebody to fill out. It's very easy, very fast.
Yes. I mean, even let me tell you, even we don't do that, but even a nurse can apply it. I mean, because it's a very simple questionnaire. I like that because if you have they are very complex scales that they are not useful for clinical practice. They are not. That's why we use this. And this is what we found. Here is the 5 patients. First, I mean, remember that we have here the final number for the scale, final score. This is the first patient beginning, and after the practice of century praying. All cases improve. All the 5 cases improve, and it's interesting. Not only the improvement measured by the scale, it's also interesting when you talk with them. That is something that is more subjective. But when you talk with the women, tell me, oh, I feel different. My life has changed. I will continue practicing centered praying because during these days I have changed. I have a lot of enthusiasm for my life. I mean, it's these are things that they are not measured by a scale, but a doctor, a physician, can feel that. That's why I was so happy with that. Let me tell you.
What happened to patient number 4?
Oh, it's not there. Oh, improvement. Excuse me. It's a. I remember it's something about like this. It's 20. Yeah, it's a mistake. It's a mistake. It's a mistake in the PowerPoint. Don't worry. I will tell you.
Okay,
Uh,
I was looking at all of them and I saw
yes,
number.
yes. Let me tell you something. Something that we will need a greater sample. But those cases who have a higher score were raped. I mean, these 3 cases were raped, and these cases suffer a sexual abuse. We cannot have a conclusion because we would need a greater sample. But to be raped means something very, very, very important for women. There is something that I'm going to study when I publish the paper. What happens if there is a comparison between rape and sexual abuse, because it's different in the magnitude. I mean, for me,
How so,
although.
Calixto? How so, Calixto? How is?
Deb, how are you, my dear? How
Hey,
are you?
well, I'm well. I'm well. I'm just curious because this is what I teach in nursing school. So I'm just curious how you differentiate between rape and sexual abuse.
Oh, very interesting. Very interesting. For me, rape is when the all the I mean the sexual activity is completed, and sexual abuse is when the woman is handled and with ¿cómo se dice? Caricias, and try to touch her and so on.
Yeah, handled with a certain amount of empathy and
Empathy and so on, but
compassion.
she doesn't want. But she doesn't want. It's something, and sexual abuse can be done even by parents, brothers, or a step parent. You know, but
Right.
rape is when the sexual activity is finished, and even can damage the vagina or of the women. That's why I differentiated the sexual. For me, both are sexual abuse. I mean,
Right. My only comment is I work with sane nurses, and sane nurses, I just was trying to understand, because if we're going to develop this research, I want it to be able to speak to trauma. So also, and Harvey, maybe I'm way off base, but when trauma is involved, there's, even if it's sexual abuse versus what Calixto you were describing as rape, there's always damage, especially in the introitus and in the genital areas. So I was just trying to understand the role of trauma in both of these different situations that you have described as separate. That's all.
Deb, then we need to leave clear these concepts in the paper we publish. I think
Wonderful.
that this is
In
very
the,
important. What you and
in
even Deb, if you can send me 2 or 3 paragraphs that you consider important
Wonderful.
to differentiate it, because it could be included in the final paper. It's
Right.
very important. Well, you are an expert in this. I'm not an expert
You
in
know,
this.
speaking of the differentiation between trauma, sexual abuse in childhood, and rape, one of the differentiating possible considerations is in the area of rape, which usually involves older victim, there is the instinctual kind of protection relative to actual survival. In childhood abuse, survival is not really the main consideration. You're victimized. But in rape, the muscles don't relax. You can get damage to the genital area. There is a question of defense. But the overriding issue for many people, will I survive this attack?
Correct.
Oh, that's
Absolutely.
important.
Absolutely. And I agree. I'm very familiar with ACEs, Harvey. I understand that totally.
Sure.
And I've had patients in the emergency room that have been raped or sexually abused, not just as children. And I think that's a very profound differentiation, because ACEs victims go on to a different lifestyle that includes typically continued abuse, and certainly which can make the trauma chronic, which of course is extremely important, particularly when the individuals become adults and they're challenged even further. And who knows, any one of these 5 participants, subjects, could have been victim of ACE, have had adverse childhood experiences as well.
Deborah, you were touching key points, and because it's true, when a woman is found, for example, in the street, and three guys took her to rape her, she's not only thinking about that she was raping, she's thinking about, is she going to be alive at the end of this
That's right.
issue?
Exactly.
It's true. It's not because it's not that a man takes a woman inside her room and rape her. No. When 3 guys take a woman and put it in and rape her, but she's feeling that she will be killed also. That's something. And in fact, many criminals rape the woman, and afterward they kill them, or they kill the woman.
Yes.
Many. Deb, Herbie, I would love that you send me any idea of this difference of rape, sexual abuse, to be included in the final paper.
Yeah, I tell you what, when we're done with this presentation, can you send me a copy of these slides and I could respond to you, and I'll look them over again?
Yes, I will send you this PowerPoint.
Send me a copy, and then I'll write you back, and I'll try to put in some kind of language, but Debbie could do the same, that survival, I attach more to the trauma of an attack, as you say, completed, that allows a person to question, do I want to live? Can I live? Will I survive this? It's a whole different set of alarm signals for the brain to defend the individual.
I do agree.
You know, and if you get down and you want to get, I don't know if you get down to more other, technical things like brain-derived neuroprotein factor and VEGF, vascular epithelial growth factor, and all those hormones that are elaborated by the brain to protect and preserve what would be otherwise dying cells. All of those particular kinds of elaborations from the brain actually stop when there is such an attack, or when someone is seriously depressed even.
Now,
Yes,
Harvey, I know you only have 30 more minutes, so I want to be sure you get through this presentation, Calixto, so that we can take advantage of time. I don't want to cut off the questions.
Okay. Well, quantitative EEG in PTSD. Let me tell you, there are many publications on this. I study many. The high beta activity in some individual showing a hyperarousal activity, theta dysregulations, and alpha suppression. In our patients, I found this pattern very well presented, in our patients. You will see in my QEEG maps what I'm showing you. You see here, this is a increment in the parietal occipital area of delta activity. And remember, And in MRI, because this is QEEG is a focus on MRI slices. I mean, I'm using what is so-called quantitative EEG tomography. I didn't want to talk too much because it's very technical. But you can see in red is the increment of theta activity, and it's related to what they call theta dysregulations and in parietal areas. And these are related probably to difficulties in processing emotional memories or integrating sensory information, because the parietal lobe is very important in this function. You can see this. This is all the patient. You see the same. Yeah, in the parietal. Remember, left is right in MRI. I mean, here is another case. You can see. You see, and this is when I present the sagittal, frontal, excuse me, axial, frontal, and sagittal planes to show the localization in this area. And this is a 3D reconstruction that I use with my Harvey. We have in Cuba a Cuban system to record and process quantitative EEG and quantitative tomography. This with my system. It's not done with foreign system. And my engineers and my computer guys do whatever I want to do, and then they reproduce a 3D reconstruction using all the slides. You see, for example, I took all the slides.
Right. In normal neural therapy that we do, our goal is exactly to reduce high beta, which would be 25 to 30 cycles per second.
Yes. I do agree with you. But let me tell you, but the pattern I found, the most common pattern was this. And that's why I am showing you. I found in 2 cases loss of alpha, and in other 2 cases an increment of beta activity in frontal lobe. But this was the pattern I found. And as we have only a limit sample of 5 subjects, of course, it will be great when we can have 50 patients or 100 patients. But it's important that in 5 patients we have a stable pattern that we have found, because the sample is limited, only 5, but I found it. You can see, and then if I was talking with Bob by phone the other day, and it was interesting that as we did this twice a day during 15 days, the patient, when we have a communication with several of the patients, and they told us that the 2 or 3 first days after practicing sensory brain, they recall too much the event. I mean that they feel they felt again very clear the sexual abuse or the rape, but afterward it was disappearing. And continuously. That's why if this is the grand average of the beginning, I took the 5 patients at the beginning. This is what I found. In 10 days, I have this. I mean, it's only limited to this area, but at the end, there was clear, no delta activity. I mean, for me, it's amazing results, because I have done many studies on quantitative EEG, and you need many patients or many cases to have a pattern. But we found a pattern in this with this limited sample, and this is something great for me as a researcher. How I can how do you have it?
Just a second.
Yes,
did you say at the end there was no, did you say no delta activity? Is that what you
No,
said?
no increment. Delta activity they have, of course.
Yes.
But this is measure this measure incremented that activity over two standard deviations regarding the normal values. I mean, I would show you because then here the scale will show you that this is a comparison with normal values. It has more than two standard deviations to
Is the
say that
red,
this is
is the red high beta?
no. This is no. The red is higher delta activity compared to normal values.
You said delta? I couldn't hear you.
Delta.
Yeah.
Delta.
Yeah.
Okay, and then to discuss this, we have many ideas. We think we need to think about functional connectivity, and that is something very that we are finding everywhere. Does sensory brain change anatomic connectivity? Probably no, but we will need to do MRI study. But functional connectivity, yes, we can change the pattern of interaction of different areas. You can see here, for example, if this was a case, it was a case of autism. I studied hyperconnectivity, and after treatment, they have the hyperconnectivity was decreased. And then we need to go what Harvey does every day. No? We need to compare this with the consciousness studies and cognition and feeling and emotions. It's difficult to discuss, but we have the ideas how to discuss that sensory brain cures in some way all the flashback, all the bad feelings or sin, yeah, and we have weapons to discuss this in our paper. The only thing I have been doing a huge research of paper, and I think that we should go for the area of functional connectivity that change between after sensory brain practice. That's why I think, and I want to discuss. Tell me, what do you think, Deb and Harvey?
Yeah, I think that's extremely interesting and important because if you don't show a change and define what that change means clinically to an individual, the real purpose of the research is lost. So the fact that you can introduce something and show that there's a change in brain functional connectivity and that emotionally that patient's in a different place, that's a winning ticket.
Yes, I do agree with you. I mean, I think, Harvey, that the something that I would need from you, from Bob, of course, from Deb, is that I'm finishing the manuscript, the paper, and we always do. I send it to Bob. Bob distribute with you, Caquito, distribute with you, and then you send me notes about changes, about what we can do. For example, I didn't consider this difference in rape and sexual abuse that Deb is an expert. I did not consider that. And I think it should be included in the discussion of the paper.
100%.
And Harvey, you can also add something important clues in the discussion of why sensory brain diminish or cure these symptoms. Why we have this slide? What is changing in this brain? That the terrible emotions, flashback and so on disappear. Why? We need to discuss this in our paper.
You know, when you'll send us a copy of the draft, maybe Deb and I and Robert and so we could have another meeting after we've read it and sort of handwritten our own comments, and we could have another meeting that we could iron out the wrinkles and then submit it to you so you don't get a tremendous number of papers to have to read, but we could send you an edited copy that contains all of our comments. That would make your life a little easier. Ojalá que sí, you know.
Always, Deb and Bob also review the grammar because my mother tongue is Spanish, not English, and then they always review
no
the
me diga, no me diga.
¿Usted habla español?
I agree with Harvey's idea. I think he and Deb work up one response, and then I'll take a look at it, and we can clean up the English stuff like that. But I think the Harvey and Deb have to work on this together.
No, I remember that the other papers we published, you did the marvelous work in grammar and style. It's important. It's important, and it's necessary.
Now, are there many slides left in your presentation?
No, it's okay. It's okay. Finish. I wanted to do a very short one.
Okay,
Short,
so this is it, right?
Harvey,
yes,
I
this
agree.
is the last.
Harvey, I agree with you. And one thing I want to make sure of is that trauma and rape can be considered different. But the articles that I will send you some articles. It's about perspective. Some women resist the victimhood and don't actually see it as rape as much as they do sexual trauma. But I think that's potato. I think that it doesn't really matter as long as we get across that the intervention of centering prayer is not only centering and grounding, but it's the realization that these isolated, or perhaps not so isolated, that these events can be brought forth and reconciled. And I believe that's the whole intent of centering prayer, is to reconcile this trauma through it, to get past it and function. I mean, realize a functional, meaningful life after.
Yeah, you know, and then there's another group of patients who have had sort of lectures by various practitioners ahead of time. Say, if you ever get raped, because I've talked to some of these women, don't fight it, relax, let it be. You will be less injured that way, etc. And they try to take a whole different view of this based on sort of preventive trauma training. And if you spend more time with these women, there's no difference. They were traumatized, and that relaxation kind of preview doesn't really change the ultimate facts.
Right. Because it is fight or flight. So
yeah.
it's physiological.
Yes.
Well, I'm the only one here that doesn't have medical training. So if you'll entertain me with some patience, because I'm going to ask some questions that probably you already know the answer to. But anecdotally, the reason this got started is I had several people I taught this to, that 10 people, and one of them I ran into. I said, "How's it going?" And he said, "Well, I suddenly became fully aware of what actually happened to me in Vietnam. Obviously a PTSD moment, not rape, but what my question is what I found intriguing about that experience was the fact that my understanding of PTSD is that it doesn't often show itself in the memory. In other words, people will suffer from PTSD, but they don't know the trigger memory. And this prayer practice can unveil that. And my understanding of our study is you were dealing with patients that already remembered what the trigger was. Correct, Calixto?
Yes.
And how can we enter into this story, that discovery process, which to me goes even deeper and earlier on in the cure, or not cure, but the treatment?
Oh, yes. In literature, you find many patients that they don't remember, or they reject to remember the sexual abuse that occurred in childhood. And using hypnosis or other techniques, you can discover what happened in what really happened in this case, in this patient.
This gets into when I used to do a lot more in the legal cases here, where we had to describe such events as suppression versus repression. and we had to define these words, which had different definitions by different practitioners. But one is largely conscious, but not entirely, and one is largely unconscious, but not entirely. And when the body cannot handle the immediacy of the trauma, that becomes automatically hidden or suppressed. And when the body does it automatically, we say repressed. And when such a time comes that they can remember that initial trigger and actually have the capacity to deal with it, when you convince them in therapy times that you're no longer that helpless person when the event occurred, then that work of repression gets undone, and you can take a look at some of the initial triggering events that were too traumatic to handle at the time.
Does that lend itself to be included, at least discussion-wise, in the paper?
100, well, maybe not in a pilot, right? So anyway, I could be wrong. That's just my thought. I think in order to streamline and highlight our results, I think we need to keep the potential noise down to a minimum. But that's just me.
Yes. Yes.
Yeah, I agree. You want to give a pointed paper. You want to be, eliminate as many variables as you can. Certainly, that's what I observed. It may be a potential for something.
The important issue is that I will submit to you a draft that will be changed. We will do all necessary changes. And there is a saying in Cuba: cuatro cerebros piensan más que uno. 4 brains think more than one.
Yeah.
Yes. Or think better than one. Yes,
Well,
I think it's important.
what are you looking at schedule-wise, Calixto? When do you think you'll have the paper draft?
I think that you will have the draft in 3 or 4 days.
And if you send also the PowerPoint to me and Deb.
Yes, I will send you the PowerPoint. You know why? Because when I was analyzing the cases, I was at the same time I'm writing. I mean, I used to write too much, and then I did the introduction, material and methods, and so on, and that's why. And so part of the discussion. I mean, that's why, because I work too much on this, and that's why I will have I have a more or less a great part of the paper already written.
So you're close, within a week or two or something like that? Is that what
you're saying? Something like that. Something like that. Let's say a week or two.
So I have a question. Are we presenting this? You're talking about preparation for publication within the same journal system that we've been previously publishing, correct?
Yes, I mean, first you revise the manuscript. When it's ready to be presented to the journal, we present it to the journal until you approve the final paper, the final manuscript.
Right. I was just confirming that it is the same journal that we've previously.
Oh, yes. I think that we have gone well with this journal.
Oh, yeah. I was just curious. That's all I was curious about.
Yes, I will. It's Word. I don't remember exactly. Word.
World. Something. Right.
Word something.
Correct.
Yes. And it's important that in the same journal, we have all the papers.
Right. I was just asking for verification.
Now, one question, the PowerPoint presentation that you do send us, ultimately, this is just a first draft. I didn't see any comparison between the patients and the control group in these.
Because really, they did it. I mean, the control group were normal. I need to remember one of the critiques you made to me, or I think it was Deb or somebody, that I didn't mention that in the Parkinson paper. I didn't. Yes, some of you or Deb told me that. Yes, of course, we need to mention that.
Well, I think,
I
think that if we
excuse.
Go ahead.
Something that we need to probably to measure the next time, because all women, the normal women, told me at the end, "Oh, I feel whiteness. I feel too much better in my life." I mean, the normal women, not rape, not the sexual abuse. They told me, "Oh, I feel, oh, my life is better now." Something that they told
So
me.
For the person that's a non-scientist, I think it might help in one or two of these slides to show the control group, even though it's a normal image.
Yeah, yes, yes. Oh, let me tell you, probably this will not, surely this will not be the final figures,
Yeah,
because
exactly.
I need to handle the figures with the scale and so on. And this will not. I mean, I will arrange the figures because we need to be very careful for presenting to the journal. I mean, I will do better 3D reconstructions
Right.
to present the scale, because Harvey, for example, Harvey made a important question. What about, is beta, is theta? That's something that I need to arrange.
Okay.
Good.
Now, are there more slides in this presentation that we haven't seen?
No, no, no. This is the last.
Oh, okay.
Because Bob didn't tell me to prepare a presentation, but I say, how do I present them what I have found? It's very difficult. That's
No,
why
I
I
think you did a
prepare.
good job. I'm glad you included this in a PowerPoint. That was powerful. That's good. Thank you.
And in the future, I think this could be the best way to prepare a short PowerPoint to discuss. And Deb, if you, moreover, Harvey and Deb, and if you have quotes, I mean, papers that we need to quote in our paper, please send me to include in the citation.
sure. No problem. I have one question. So I just want to make an anecdotal comment, especially when it comes to psychiatry. I mean, I'm not sure what you mean by normal, but I would imagine that normal would be defined as not experiencing the events.
And no neurological symptoms, no clinical diabetes, no hypertension. I mean, not any systemic disease or neurological disease, and of course, to be sure that they didn't suffer any sexual abuse experience. That's
Right.
very important.
So no physiological comorbidities or anything like that, right?
If you want that, send me a paragraph describing what is normal. This is very important because it's important for the publications.
Right.
Normal soldiers are considered those. Blah, 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 blah. It's
Right.
very important for
Right. I
publication.
wanted to make sure I understood what we were actually referring to when we talked about normal. That's all.
Well, in Cuba, Bob considers that I am not normal because he's a German and I am a Cuban.
Well taken. I'm also part German and part of a whole lot of other things. So quite well taken. So maybe none of us. Well, I don't know.
Yes. Well, we think that we are going to do a great job with this paper. Great job.
I agree.
Sure.
Wonderful.
Now, are you going to have video for the patients? Did you do that yet?
Yes. Don't worry. Janine is doing that. Janine is taking care of that. It's taking care. Well, I will continue working until now. When I close the Zoom meeting, I will continue managing the figures and so on, and you will have very soon the first draft.
Beautiful. Well, it's really good to meet you. This is such a pleasure to get a chance to meet you for the first time.
Harvey, Bob is the chairman, and Deb is also the chairman of the chairperson. I want to meet all of you, and then I would love to go again to Houston. The last time I went, I was sick, and it was very bad. I was sick with a sleep apnea, and I felt very bad. It was in 2000, a year ago, and I really Bob, it needed to be my my doctor.
You had food po- you think you had food poisoning. That's what it was. So I gave him some
But
Cipro.
I'm looking forward to go again to Houston with you and so on.
Well, I
That's
think
great.
the
And that
idea,
you come to Cuba.
I've been to Cuba. I gave a lecture once at the Congreso Mundial in Havana.
Oh, see.
Yeah. And
Oh, you must come. You must
I,
come again.
I
You
have
must come
learned,
again.
yes, I've learned that, like you're saying, 4 brains is better than 1 is, I remember in Spanish, a famous refrain that I always liked, which is, más sabe el diablo por viejo que por diablo. Quiere decir que la experiencia vale la pena, entonces, you know?
That's a great saying. A great
Harvey,
saying.
you
Yes,
speak
great saying.
Spanish, Harvey?
What's that?
You speak Spanish?
More or less, mostly less. Menos que más. But yes, I understand quite a bit of Spanish, yes.
Thank you.
Okay, well,
I gave en una entrevista en Telemundo hace muchos años.
sí, no me digas
De
Telemundo.
veras, yeah.
Well, when you come to Cuba, you will present your lecture in Spanish.
Yeah. Qué mala suerte. Me dio qué mala suerte en este momento.
I am able to organize a seminar here in Cuba for discussing all our research. You can come, the group of the network, and I can organize. I can invite a group of Cubans and so on. It's neurologists, neuroscientists, psychiatrists, and we can discuss and present. You present the lecture, Deb, you, and so on. We can do something.
Well, let's work on the
Next,
paper first.
when's your next conference? When's your next conference on disorders of consciousness?
Oh, to be sincere, I am waiting the country stabilizes a little because that now we are living a very difficult time and from related to the economy, and we have many problems with the economy and so on. And we are also waiting for the U.S. president to know what will happen with us and so on. And let's see, but probably in 1 year or 2 years. I need to organize because Harvey, Bob is asking me because I have organized 8 international symposia on brain death and disorders of consciousness, and that was one of the sessions that Bob joined a group of Cuban neurologists, and he did a century praying session, and the audience was. They told me, what happened here? What happened? They thought that God had come.
He did. He was already there.
Well, I wait for you. You wait for me. Don't worry. I'm working very fast.
Okay. Well, we'll get together again, and once we get, I'll love to review the slides again, and then we'll get a first draft, and then I know Deb and I.
And please be free to criticize the draft. It's very important. Más sabe un diablo por viejo que por diablo. It's very important that, as we have done before, to be very critical on the draft and to have a very good paper.
Ya entiendo. Poco a poco vamos a tener éxito.
Poco a poco.
Punto. Sí, yo lo entiendo.
Well, I know your time was limited, Harvey. If the rest of you want to stay on, Deb, it's up to you. But I think we covered everything we need to, or whatever.
I think we had a really meaningful discussion, and I think we have a lot of information to go forward and kind of collect our thoughts as far as Klesel is your draft. And I have to hand it to you. You're actually very eloquent for ESL. So thank you. And I believe that the few minor maybe concerns, a couple of definitions and maybe clarifications. I think past that, everything seems to be good, especially when we can see the test group versus the experimental group.
Okay. Well, is there any way you can finish this, or I love to see Bob's face, but
All right. Well, I'd like to say see you in Cuba.
okay. We will meet very soon. Don't worry. Either in
Okay, well,
Cuba.
we'll see you. I guess we'll see all of you.
Okay.
I love
bye
you.
now. It's a pleasure.
Bye.
Thank you. So thanks, Harvey. Thank you,
My
Deb.
pleasure.
You're welcome.
Bye-bye.
Bye-bye.